Hi, it's John Kanellopoulos in our center here in Athens, Greece, the Laser Vision Ambulatory Surgery Center. We have here a young lady who we had performed Athens Protocol several years ago in 2020, so it's been 5 years. She was stable for 3 years. Unfortunately, she did not seize the habits that created her keratoconus, which is obviously eye rubbing. We can tell that this is a treated eye because the cornea is more irregular on the back side than it is on the front side. But the epithelium here being blue tells us that she's an avid eye rubber. She sleeps face down and rubs her left eye a lot, and her keratoconus has worsened. So now we can see the residual cornea thickness here by OCT is only 370 microns. So when we plan our topography-guided treatment, we can't really treat centrally. So we will, and I'll walk you through this, we will treat some of the astigmatism. So we'll treat 1.5 diopters of astigmatism. And please note that the axis of the astigmatism is the axis of the topographer and not the refraction. And here we cannot treat myopic. So we will arbitrarily treat hyperopic. You do not have this option in the US. So we have to talk separately on how to do this in the United States. What I'm trying to do here is take away all the treatment that we performed in the central cornea or in the thinnest part of the cornea. So if I put a +1, look how this treatment is converted. It's hotter in the periphery, and see that we've increased the transition zone. It's weaker over the cone. And we said the cone has really no room to work. It's very thin. So alternative here is a tissue enhancing procedure like KIRS or CTAC or a cornea transplant. Besides performing an Athens protocol that, as you can see here, despite the fact that the patient is myopic, will be a hyperopic treatment in order to remove as much as possible the treatment in this area here. So I'll go all the way up to a +2.5. So by normalizing this cornea, I'm essentially treating very little in the center, almost nil, thus generating more myopia but normalizing the cornea and avoiding cornea transplant. Let's see what happens when I reduce the astigmatic correction. Not much of a difference, so we can definitely work on this. And I'll go all the way up to +3 because I really want to take away the treatment over the cone area. So when I go to +3, there's very little treated here. So I'll stay with a +2.5. So this will be our treatment, transepithelial, because we will proceed after this treatment with removing 40 microns of epithelium in order to use the remodeled epithelium as a masking agent. Hope you found this description of a very particular Athens protocol, because this is Athens Protocol number 2. We treated in 2020, so 5 years ago. We have recurrence of keratoconus from avid eye rubbing, and we will adapt, we will modify our treatment so it will not treat almost at all over the very thin part of the cone and mainly the periphery, knowingly creating a little bit more myopia than the patient has, but we can treat that if, God willing, the cornea stabilizes with a soft contact lens or a phakic IOL. John Kanellopoulos from Athens, Senegal.